house rules, basically about online meetings. Please ensure that any mobile devices, Alexas, Google Boxes, mobile phones are switched off. Only members of the board, members asking questions, the clerk, the officers presenting reports will be allowed to speak. If you're not currently speaking or being asked to speak, please mute your microphones. If you don't mute your microphone, it will be muted for you. To assist anyone viewing the meeting, please can everyone turn off their cameras and only turn them on when asked to speak, apart from me. If you have background selected on Microsoft Teams, please don't move around too much to avoid blending into the background. And please do not use the meeting chat function on Teams because it appears on the webcast. Now, I'd like to introduce members of the board and the officers supporting the meeting, just so everybody who's listening knows who's in attendance. So first of all, members of the board, Carol Camis, Ulla Corinne-Clark, Bill Cook, Graham Ebers, John Halsall, David Hare, myself, Charles Margates, Debbie Milligan, Meriden Peachy, Matt Pope, Jim Stockley, Katie Summers, and Chris Trail. And officers supporting are Madeline Shopland, Narinda Bra, Peter Slade, Lewis Willing, Martin Sloan, Andy Fitton. I think that's everyone. The meeting is being webcast and will be available to view online at a later date. And I'd like to welcome new board member Chris Trail and also an opportunity for Health Watch to introduce Neil Bolton Eaton. Good. So first of all, apologies. Are there any apologies for absence? Madeline, do you want to go through that for me, please?
Yes, we've had apologies from Tessa Linfield and Sam Burrows.
Okay, thank you. Then it's minutes of the last meeting, and can I also members for agreement to the meeting? And so has anybody got anything from the last minutes they want correcting or altering or amending? Okay, so that's good news. Declarations of interest, any declarations from interest from anyone? No? Okay, public question time. To the best of my knowledge, we've got no public questions. Madeline, are there any you're aware of?
No questions, Chair.
Okay, thank you. Now, member questions. Now, I've got a question here from Gary Cowan.
He's not present, Chair.
Okay, so is the format then, Madeline, he gets a written answer to that?
It would be, yes.
Okay, thank you. Well, we will do that then. So that's that. So we're on to the first agenda item, which is the mental health crisis review. Now, is Andy Fitton present?
I am. Thank you, Chair.
All yours.
So sorry, I missed the beginning. Do you want me to turn my camera on or off? Sorry, I didn't quite get the rules of the game.
The rules of the game, please keep your camera on, and I believe if there is anything written with this, then I think it's Narinda is going to put it up on screen while you're talking.
I did say I would do that if that was necessary. So Narinda, if you'd like me to do it, I'm happy to do it.
Yes, that's fine. If you could just put that on, Andy, that'd be great.
Okay. Chair, I hope that's presenting.
Yes, I can see that here.
I'll go to the top if that's okay. I apologise. Hopefully that's a reasonable thing. So thank you for inviting myself, Andy Fitton. I'm the Assistant Director for Joint Commissioning Berkshire West CCG, and we take a lead on adult mental health. And this is what this report is looking to provide the Health and Wellbeing Board with updates on two bits of transformational work. One is the mental health crisis review, which has more information. And then secondly, we're on the journey of building a primary care mental health offer. Got a bit of an echo. I don't know if that's coming through to others.
I can hear you clearly, so please proceed as far as I'm concerned.
Great. So I'll start with just...
Chair, there is a lot of background echoing going on. I think it might be, Charles, might be your actual system. You might need to mute whilst Andy's speaking.
Okay, no problem. Let me just see how I can...
Okay.
I'm muted now, Andy.
Thank you. So You can see in point 2 of the document here that we initiated the review due to a number of reasons, not least because of the number of feedback that were coming from patients, service users and carers looking for improvements over the time. And that also came through with work that had been done through local organisations like our Health Watch partners, as well as the hospital. We've also had meeting the ambitions of the NHS long-term plan that came out last year. So this has enabled us since the beginning of 2019 to now to complete a very significant piece of engagement work across the partnership and with parents, with carers and patients. You can see under 2.2, we've indicated fairly clearly the amount of work that this has taken. And what we've done in particular is spent a lot of time talking and learning from the experiences of frontline staff and from carers and patients that would normally be using crisis response services. What we were very keen to also do was to look at learning from other places around the country that have all sorts of different sort of initiatives and successes that we could learn from, and that's been drawn into our review, looking at places locally like Oxford, as well as down on the south coast, but also looking at areas such as Cambridge and Peterborough, who have invested and done something different 2 or 3 years ago. And finally, what we also obviously did was look at some of the data and some of the performance information of some of those organisations that we currently fund. Chair, that has led us to be able to put forward 14 recommendations, which have definitely been shaped by the engagement work of our partnership that includes voluntary sector, as well as the health sector and local authority sector and patients. The themes are probably the key thing to look at in the broadest context, and then maybe people would ask for more detail you can see on the report. So the first theme is around the single point of access for mental health crisis that's consistent and available 24/7, so all day, every day across the year for all ages. And you can see there's some very clear recommendations, and what's really encouraging is that we're making progress against them already, even actually accelerated because of our COVID-19 requirement response over the last 3 months. This will be all ages, and so we would definitely be looking to incorporate this to include a children and young people crisis model offer, as well as what we know is the volume business is with adults. You can see there's a significant number of recommendations in that first theme. The next piece of work is to try and develop some alternative crisis provision to things like people turning up at access to A&E and to Prospect Park Hospital. And this is where particularly we've been looking at other provision across the country to set up a new offer, which we would call a crisis cafe, and we've been looking at terming it something called breathing space. We'd want that to be delivered primarily by a voluntary sector provider and with BHFT. The ambition is to have that crisis cafe in every single local authority over the next 5 years. And what we would want to do is to see that as a model that is responsive to the local environment. So it doesn't have to be the same in every single local authority. What we want to see that do is therefore have an impact on the care pathway, meaning that young people and adults would actually have an alternative than just turning up at the hospital and asking for support there. We already have a street triage service, and that's an alternative to crisis, which works alongside our police colleagues who, when they come across a person who's having a mental health crisis episode, they can get the right mental health support before they take action. And we want that to be sustained and stabilised and linked long term with our colleagues in SCAS who run the ambulance service to make sure that that is also available. The next themes are obviously linked into other bits of work. So we'll talk a little bit about the primary care mental health, so having an enhanced better access to preventative support, and making sure that there is strengthened peer support offer that would go complement the primary care offer. We've recognised that we need to do more on the communication and marketing of that crisis offer across patients and partners like the police and ambulance when they actually work with people. So that's something that we need to put more time and energy into. We recognise that it's important to improve our education and training so that people who are delivering response across the system, be it police, ambulance, schools, everybody understands what mental health and mental health crisis response looks like. And then we would be looking to try and establish some effective clinical governance and partnership governance in this area going forward. So they're the 14 recommendations, Chair, about that particular piece of work. Before I finish, I'll also touch very quickly on building a primary care mental health offer, which is looking to complement both what we would consider to be a robust secondary care offer in Berkshire Healthcare Foundation Trust and the support of the crisis support that we've just indicated. What we're looking to do, obviously, is to provide something that can prevent escalation of needs by providing that support as early as possible. It would be built around our GP primary care alliances, or the PCNs, as they're now phrased, and that it needs to be built in there such a way that then could be integrated into our acute and secondary care support offer, so that when the people do need to get their support from secondary care, they can get it with speed and with efficiency. I think the other thing that we've learned looking at other models that this model needs to be is it needs to be integrated with the voluntary care support on that well-being and the public health offer. So we know that you're looking to drive recovery by making sure that people have a robust community support package, not just the health support. And so that what we're lucky is that everybody has massive assets in their communities, and we just need to make sure that feels coordinated and linked around emotional and mental health. We're at the point where we are really excited to be working with a group of health and senior LA leads to do that. And we've been shaping a model which we have drawn heavily on others like Cambridge and Peterborough again, who seem to be doing really well in these areas. So going forward, we'll be working closely with our clinical directors of the primary care networks, and we've made that plea out with support just recently after COVID responses changed, that we can do more work on this in the next coming months. And so we're hoping that we'll be able to bring something back with more detail in the future, Chair. Thank you very much.
Okay, thank you. Basically, now the way we're going to do this now, I'm going to go around each board member in turn in alphabetical order this time to ask them if they want to speak. I'd ask that anyone who's referring to the report or making specific comments just says the page number or the section so everybody can see what we're talking about. Once everybody's spoken, I'm then going to proceed to a vote. The way the vote will work, board members will be asked only to speak if they do not agree. If there is no disagreement, then we are assuming that that's approval. So I'm now going to go around everybody one by one, starting with Carol. Any comments, questions?
No, I don't have any comments or questions, thank you.
Ula Corinne?
No, nothing.
I don't think Phil Cook's here, so we'll go straight on to Graham Evers.
Sorry, Charles, I am here.
Oh, my apologies.
That's all right, but no comments.
Graham?
Just that it would be good to see the granularity and the specific actions flowing from the next steps and clearly attributed to the responsible organisation to take it forward. But yeah, a positive and welcome move forward, I would say.
Andy, did you want to come back or comment on that, or?
Chair, I'd be very happy to come back maybe at an appropriate time that you'd feel welcome to give you that implementation plan, which I think is what maybe would be how I would interpret the request.
Okay. John, any comments, questions?
I welcome it and I support it. Thank you.
David? Debbie?
Can you hear me? Sorry.
Go ahead, David.
Couple of comments.
One, patient involvement. You said there was patient and care involvement. I couldn't see that on the paper that much, and certainly practitioners see things very differently from patients. And I think it's very important to make sure that you have the patient involvement was there, a good amount of that to give you the patient perspective, and that's 2.2. The second one is under 3. You say that you want to move services away from secondary care towards primary care. I know my wife's a GP that often primary care wants to use secondary care for mental health and doesn't always have that facility, and that's putting it nicely. And yet you say, and it's very true, that early intervention means that people get better quicker and don't degrade to such an extent. What are you going to do about that situation where you need a little bit of secondary care and then they can go back to primary care?
So your first point about patient involvement under 2.2 of the report is that we have done extensive amount of work with patients. So just to record is that people, Philip will understand that we ran patient engagement events in every single local authority that our voluntary sector partners helped us organise. We worked well with some of our recovery college work, particularly in Reading, where they introduced us to patients they thought would use the thing, so we could do direct contact with them. We have done work through patients up at Prospect Park Hospital, through the user groups there, to get their insight and involvement. And we were very unlucky. We had a very extensive arrangement to be done up in West Berkshire, and it was all ready to go. And literally, it had to be cancelled because of COVID-19 in March. So that was the last bit that we were very disappointed, as they were, about, because we had actually had a good response. So I feel we've done a really significant bit of patient engagement, and I apologise. I tried to keep the report quite sort of short, and sometimes it's difficult to know how much detail to put into a report.
People want to know.
Yeah. Okay. Any other comments, David?
There was the comment about secondary care and primary care, and a good liaison between the two, because sometimes primary care wants a little bit of secondary care input and then it can go back to primary care, and often they don't get that input and they're left holding the baby.
I think you've absolutely captured the spirit of what we're trying to achieve, and I think there are two significant bits of work that we need to get right. First of all, is we probably need to put some mental health expertise inside the GP surgery environment, so that they can actually have direct access to those people to do the early intervention as soon as possible. The other thing that we're exploring is that how we can have more regular consultation between GPs and secondary care. And actually, again, COVID has helped us enormously, because it's really revolutionised some of the digital working that's been happening across primary and secondary care in the last 3 months. So again, we're looking to really build off that momentum. I suppose the last bit is what I think people are talking about, is that we do need to create a pathway out of secondary care back into primary care, because there's a lot of people that don't get discharged because people are worried that their risk is too great to go back into primary care. So we see that actually, if we invest in providing a more wraparound support inside primary care, then we will actually free up more secondary care to meet the need that does actually require it, and get to them quicker, because I think that's part of the problem, is that people feel they have to wait a long time for a secondary care response.
It is.
Thank you. Now we'll move on to Debbie.
Yeah, I mean, I think the paper is great, and to kind of support Andy, having a mental health practitioner associated with PCNs, we had them years ago, they were fantastic, so it's great to see them back. And also, I think I agree that COVID has changed things. So trying to get hold of a psychiatrist during COVID has been relatively straightforward, and they get back to you very quickly with brilliant advice and written advice as well. So we don't want to lose what we have learnt through COVID. So yeah, if you can add that in, that'd be fantastic.
Okay, thank you. Meredith? Sorry, go on, Meredith.
Yeah, I just wondered if you made a point about improving the public health. I just wondered if you could expand on that point.
Sorry, yeah, I'm not saying we should improve the public health. What I'm trying to say is I think we need to make sure that we're connected to the public health offer and the wider voluntary sector offer. So that well-being perspective on making sure people live as healthier lives as possible, which includes emotional health as much as physical health. So volunteering, peer support, accessing adult education, good physical activity. They're all real preventative and keys to maintaining good emotional and mental health that we mustn't forget when we're building this offer.
Oh, excellent. And do we measure the number of people who've got mental illness who smoke, for example? Because they tend to smoke far more than the general population.
What we do is measure the number of people who have significant mental illness who go through a health check to try and prevent these kind of, like you suggest, other problems. So I don't know off the top of my head, and I don't have that information to hand, but we do measure the number of people that are accessing the right general practitioner advice around preventing smoking, alcohol rates, stuff like that, which, you know, you're right, because of the people with significant mental illness die earlier than the general population, and they're some of the key reasons why.
Yeah. Okay, that's great. I think that's absolutely spot on. If people are accessing equally access to health checks. Thank you.
Okay, Matt, any questions?
Just to support the paper, really do think this is a good way forward. Andy, I would welcome a conversation outside of the meeting to maybe establish some of the links we just talked about. And I think the other thing for me is I'd like to discuss whether there could be a commitment to having a crisis cafe in Wokingham earlier than inside the 5-year timescale. I think this would be really useful, and I'd like to have a chat about whether we could pull that off.
Yeah, of course, Matt. Yeah.
Okay, Jim, any questions?
Nothing to add to what's already been said.
Katie?
Yeah, just to say, Andy, I think it's a very good paper. Just following on, I think I'm really celebrating the fact that you are starting to realise that the work of remote access and digital could really support individuals. I think that's very, very good. I will touch base with you offline though, Andy. I think that there is an opportunity with all of this on actually trying to think about the predictive modelling of people that go through a mental illness and at what stage. And I think if you look at what you're proposing here, that is a considerable amount of workforce, and therefore we are needing to know that actually have we got the right level of workforce going forward, and actually when do we need to also increase it or actually redeploy it into other areas. But if I speak with you offline, Andy, because I'm doing some work on that already, and I'd be able to feed that into you and the mental health teams also across the local authorities. On the point, Meredith, of smoking and mental health, yes, we can actually record that. Meredith, I can give you a deep dive report that's actually from GP practices. If they've recorded smoking and if they've also recorded the mental illness, we can give you that down into each practice.
Okay, thank you. And last but not least, Chris.
Thank you, Chair. Just a very quick question. Andy, it was a very good presentation. I thought you told us a lot, but in terms of what success will look like, we irresistibly in the public sector move towards numbers and, you know, what goes down and what improves. And given that we're in a COVID crisis where mental health issues will emerge over a period of time, how will we make sure we get the texture of levelling out the delineation of more people emerging with mental health issues during the COVID crisis and beyond, and the success of this work? I know it's a bit of discuss in 10,000 words or less, but hopefully you get my direction of what I'm asking.
So pre-COVID, and I think we need to reflect now based on COVID, but pre-COVID, for the mental health crisis review, we were talking about some impact indicators to follow on numbers presenting at A&E to try and see a reduction of those. And also under the Mental Health Act, when someone is put under a section 136, that also is quite a sort of negative outcome for that person. So we would look to track that as an impact indicator. And then how many people end up what they call on a place of safety and then end up on a section 3 of the Mental Health Act. So you can kind of see as there as like trying to prevent those numbers from increasing, if hopefully seeing them reduce. So they would be our kind of mental health crisis canaries that would tell us that it's working well in the mine, as it were, to use that analogy. In terms of primary care mental health, I think you'll see in the paper we talked very quickly about looking at driving up recovery rates, improved self-care and demand on secondary and acute care decreasing. So I think part of the demand management would be that we would see that the right people need to get to secondary care and quicker, and that would probably be a really key indicator, and seeing that there'd be a patient experience would improve on that basis. In terms of driving up recovery rates, we'd use some of the data and some of the models coming out of our talking therapies, which have a very good evidence base and showing that they've got very good recovery rates. And so our mental health interventions would have to be based on similarly interventions that could be evidenced, and we could, whatever service we do that would have a similar sort of evidence base of saying the recovery rates of the people using it would go forward. The improved self-care is probably more difficult, but whether we could see that GPs could be reporting saying that because of this, they're seeing a decrease in the number of people of repeat use of their service. Because I mean, Debbie's in the room, she'll speak to it better than me, but my understanding is when people need mental health support, they often come in episodes of regularity. It's almost like a machine gun effect until they get what they need or whatever it is. So maybe that sense of self-care and self-help, if we've got a better sort of a well-being offer around it, would actually mean that people don't then present back at the GP so frequently and with such insistence.
Okay, many thanks, basically. So what I'm going to do now is ask the board if they agree to note the report. If you're happy, please remain silent and please only speak if you disagree. Well, I think that looks good, Andy, so I'll say thank you very much.
Yeah, appreciate
and we'll move on to the next item. Thank you.
I'll leave if that's okay. Thank you.
That's fine. So could I now ask, please, Martin Sloan to talk about designing our neighbourhoods and an update?
Okay, thank you. And basically what I wanted to present then was an update on the recommendations for taking forward a neighbourhood approach as opposed to being a project in its own right. I think it's really a way we need to work. And what I wanted to do was really just to give an example of what we've been doing over the last COVID period of really working at a locality neighbourhood level. And then out of that, then when I come to the recommendations, then you'll see that it's an approach to how we take forward other work. And I've got my recommendations. So just go on to the second slide. So through the Wokingham Partnership, we've been involved in population health management and worked through Optum. And we've done a lot of work on trying to use the data to actually target and proactively manage our population and improve their health and well-being. On to the next slide. The challenge then we've had through COVID then was basically trying to create an integrated and coordinated approach, tailored and a proactive approach where we actually try and contact people and make them safe before they get into a crisis. So we've been working on both a shielded list and a non-shielded vulnerable list, and we've basically been meeting their health needs. A lot of access to food, medication, social isolation has been a big issue, and welfare checks. And we've basically worked as a system at a neighbourhood level to actually reach out and support all these vulnerable clients or patients in Wokingham. So what we did then was we've combined a lot of data. So we've done a huge amount of work working with each of our 13 GP practices, pulling data in from GPs in terms of who they felt were vulnerable, along with the government shielded list. We've established a combined database, and then we do welfare checks. And it's really how the whole system has worked together. So we had social prescribers in practices, then they are speaking to people, they then refer into the link scheme then to then do welfare checks. Equally, the link scheme, when they've been dealing with people, they've then gone to a local group, and we've have nine local groups working in sort of neighbourhoods that have then provided significant local support to people. Next slide. So in overall terms, and we basically have done a huge response with citizens advice doing the front door, over 10,000 calls. The community hub have managed food packages out to over 900 households. We've had 800 prescriptions delivered. The welfare checks have been really significant. 2,500 plus are getting regular welfare checks, and we've had a huge volunteer support. And also 9 local groups, and so we've really built up a real momentum about having local responsive services, and that's really been a neighbourhood response. So on to the next slide. Then where we're at the minute then is we keep going with that. So we're working really closely with our GP colleagues then to identify the next cohort of elderly and frail. We're using a population health management approach. So we're looking at the electronic frailty index, and they're bringing through more data to us. We'll then contact the people through our adult social care teams, and then work with the voluntary sector and our local groups to deliver that. And another thing just to note, which is one of our sort of latest key areas, is a number of the shielded residents who have been inside for 12 weeks have now started to lose their mobility and confidence. So we're now looking at how do we work together through volunteers and our OTs and sport and leisure team to try and actually have a reablement programme to get the vulnerable people who've been stuck in their own homes have the ability to actually get outside again. So I just want to sort of say that as an example of, you know, neighbourhood working, where we've worked really closely with voluntary community sector, we've worked all together, and therefore people have got a very local response and working at a GP level. So then coming on then to the recommendations of our neighbourhood approach then is to say we need to use that as an example. So there's no right and wrong way of doing this. We just need to do things at a local level. So we've just agreed our Wokingham voluntary and community sector strategy with a focus on integration of services at neighbourhood level. So what we want to do then is to actually, to implement that strategy at a neighbourhood approach, and that then will progress the project. Equally, we're coming on to later the strategy into action plan, which is how we take forward our 3 priorities of the wellbeing strategy. And again, what I'm proposing to say is we'll take that strategy and we'll develop actions local to each neighbourhood and take that as a way leading. And then in support of those 2 key areas of work, we're going to undertake a mapping exercise by the end of November of all the sort of local neighbourhood resources which support the 3 priorities of the wellbeing strategy. So that will then give us what local resources and how do we then integrate and maximise their use. And we're also going to set up a partnership forum to enable better communication and sharing of ideas. And equally then we'll run further events like the one that we ran in January. That was the last sort of designer neighbourhood, where we got a lot of people in a room, and there's really good synergy and learning from that approach. So those are basically my 4 recommendations to take forward the neighbourhood approach.
Okay, thank you, Martin. Now, I'm now going to go around each board member, this time in reverse order, for any questions and any comments to Martin. So first of all, Chris.
None for me, Chair, thank you.
Katie.
Well, I've been part of the conversations and I'm very, very committed to it, and I think it's absolutely fantastic. Generally, I would actually make a general comment. Wokingham is leading the way nationally with all of this now. It's now got a national profile with everything that the whole team, Wokingham Borough Council, the voluntary sector, all of the ICPs, all the actual GPs, it's been raised nationally now. So it's a big thank you to everybody.
Okay, thank you, Katie. Jim?
No, nothing from us.
Matt?
Just to put on the record my absolute thanks and admiration for how the voluntary sector have stepped up during this period and achieved all of this. Absolutely fantastic work.
Meriden?
I'd also like to say I think there's been brilliant voluntary sector support over these last couple of months, and some amazing initiatives. And I think the Neighbourhoods programme is an extremely good one, and happy to support it.
Good, thank you. Debbie?
No, thank you.
My sole comment, because I'm next alphabetically, is I think this has been excellent, a really good example of how, you know, public bodies and the voluntary sector can work together, and it's a credit to all the people who've been involved in it. David?
I'd agree with that and say, as Matt said, that what might have taken 2 or 3 years because of the COVID crisis has been done in weeks, and it's very positive what we've managed to do.
Good, thank you. John?
I would like to put on record how proud I am to be heading an organisation which has performed so well in the last couple of months, and in particular the support of the voluntary sector, which has been absolutely amazing. So thank you very much, and it's the core of our strategy now to build on that and make it a permanent feature of our communities in Wokingham, which Martin's paper is a cornerstone. So thank you very much.
Graham?
Yeah, just to say again, excellent piece of work, excellent response to a crisis. And I think it'll be useful picking up from our January, the outputs from January, and seeing what of those issues, initiatives that came out of there can be addressed through the learnings and the connectivity that's been created to date. So I suppose we've learned an awful lot, but also we need to go back to that January event, which was extremely successful, and see how we can mesh the two together in terms of taking it forward.
Fully agreed with that. Fully agreed. Phil?
Yeah, I mean, obviously we've been heavily involved in a number of the different pieces of work that have been going on, so absolutely agree and support what's been said in comments, but also what's been presented in the plan. I would like to ask though, Chair, I wonder whether some kind of short film or notice could be put out from yourself and Councillor Halsall, perhaps, quite openly saying thank you to the voluntary sector, because with all due respect, they probably won't read through the minutes of this meeting. But whilst it's on record, say either a short film or a short notice, just saying, you know, it is greatly appreciated and recognised, I think will go a long way for charities and groups.
I'd be happy to do that. John? I'd be happy to do that. John, any comments? Okay, I'll pick this up with John offline, but you know, I'm sure we could sort that out, Phil. Ulla Corinne, any comments?
No, I just want to echo what has been said, that this is a good example of cooperation, and I think it's been marvellous.
Okay, and finally, Carol.
Yes, I'd just like to say that as we move forward and it becomes more of a permanent feature, I'd like to make sure that children are also, we make sure that we develop the community and voluntary sector support around children and prevention strategy. So I'd be interested in looking at working more closely, Martin, as we get out of the crisis in relation to a longer term piece that is across children's and adults.
Yeah, that is the plan, that it's a service right across adults and children that we'll be working on, yeah.
Okay, great. Well, what I'm going to do now basically is ask the committee if they agree to the recommendations. Please only speak if you disagree. Okay, so I think that's approval. So I'll say thank you very much, Martin. And yeah, no, thanks very much. And we'll move on to the next item, which is strategy into action. And Meriden, I believe, is going to introduce a report for us. Meriden, I believe you may be on mute if you're trying to say something right now.
No, I wasn't trying to say something. Did you want me to? I think I just lost the internet for a moment. Right, can you hear me now?
Yes, go ahead.
Excellent. Okay. I am, for those I haven't met, my name's Meriden Peachy. I've been with the council just since March as your interim head of public health. In normal circumstances, I possibly would have been more dedicated to the health and wellbeing strategy and the health and wellbeing board. But myself and public health colleagues have spent quite a lot of time helping the council respond to the pandemic, as you can imagine, and has everybody else. I've had a chance to have a look at the health and wellbeing strategy, and I was asked to have a look at how are we doing in terms of progressing. And what further sort of action or thoughts should we do going forward? I mean, what's very clear is this is a strategy with 3 very clear priorities, but very ambitious. And there's a lot of good indicators, and there's a lot of action. And so it's just a fairly brief review looking at, have we, since 2018, have we improved? And what further thoughts can we do to making it happen? And you've also got a very good neighbourhoods programme, and I think this is going to be some of the answers here, is the neighbourhoods programme. So if we just move on to the next slide. Have we got the next slide? I'll use mine. Okay, I'll just go through the 3 priorities. And what we've done is a lot of the indicators from the public health outcomes framework. Sorry, can you hear me?
Yes, yeah, I can hear you, Meriden. Please proceed.
All right. Okay, so the first one is creating physical activity, active communities. Now, with all of these 3, there's a lot of indicators, public health outcomes framework, the NHS, or the social care. There are actually quite a lot of qualitative indicators that might give a little bit more insight, particularly in the shorter term, as to progress. So, for example, with the physical activity, it looks like there's less physically inactive people and there's more physically active people. Not entirely reached the target, but that looks like it's on the right course up. But how do we know whether people with disabilities, people with mental illness, and some of our more disadvantaged communities, how do we know that this also applies to them? So that's where some of the qualitative might come in. So, for example, it could be a leisure provision. You could look at the types of people accessing it. So if we move on to the next one, which is around loneliness. There's a lot of very good indicators here. But what I've suggested is even though the target is around children, adolescents and elderly, there aren't as many indicators around children. So, for example, I think the NEETs, the not in education and training, is a good indicator for the future. So there's a few additional suggested measures there, and we've also looked where some of the potential gaps are, particularly with things like systems for young carers. And the third one is the broad one, narrowing health inequalities. And I think quite rightly you've picked on 2 quite key inequalities, because inequalities is huge, but you've picked on 2 really good ones. One is the gap in people with mental illness, whether they're in employment or not. And that is a really good indicator of how the whole system supports people with mental illness. And we do know that people with mental illness, around 70% of people want to work and less than 30% of them are in work. So it could do with some short-term progress on what are their views on the services they're receiving that help them, the whole attitude and ability to be able to get into the employment market, for example. So I think that's all I wanted to say on the 3 is I think there's an opportunity to review some of the indicators, and we've given some suggestions there. There's some progress on all 3, but it could be that when you move into neighbourhood planning, there could be a bit more focus on the actions and measuring whether the actions are actually working, because there's not a lot I could see around how to measure some of the specific actions that are in place. And I do know with the children, health inequalities in children, I think there's going to be further discussions at young people's boards. And I think there's quite a bit there to look at school nurses and health visiting at the whole 0 to 19. What's the quality of the interaction between all those services that work for children in the 0 to 19 range, for example? And there's a lot of indicators around that, how good the teamwork is. It's not just about one profession, it's about how all the professions jointly work for the purposes of children. So I think the recommendations are really around some slightly different sorts of indicators, maybe a bit more of a focus on some of the actions, what people are doing. I mean, this last slide is quite a good one. And it actually shows really good progress. One of the most disadvantaged groups in society is looked after children. And that very last slide shows that the educational attainment of that group has actually improved significantly. So it does show that a lot of action is in the right place. So just some suggestions in moving forward. Ends up for questions.
Right, we'll go around this time alphabetical order for questions. So Carol, any questions, comments?
Only to say it's good to see that children are featuring more in our strategy, which I know we've been trying to do for well, since I came into post. So it's good that's now a feature. I think one of the things that I would like to add is in terms of the social isolation is care leavers. So as well as the children that are NEET, it's also our care leaver population. That would be something that I would want to put in there as a target. Other than that, I'm really happy with it. Thank you.
Meriden, is it possible we could add basically care leavers in there?
Yes, I believe we can. And yes, there's definitely indicators around care leavers.
Thank you. Ulla Corinne, any questions, comments?
Yes, you said when you started speaking that it was a very ambitious program. Do you fear that perhaps this is not going to be an easy thing?
I suppose by saying ambitious is I think it is going to be hard to achieve all the targets that's been set out. It requires huge galvanization of the whole system behind each one of them. And that's the big question, is the whole system galvanized behind them? And all of them require multi-agency support and input. And that's my point about it being ambitious. To shift physical activity in the whole population, not many countries have managed to do 1 or 2% a year change. And then there's, if you're really shifting the inequalities, are the people with mental illness, are we looking at their physical activity? When I asked earlier about people with mental illness, we tend to forget about smoking programs and people with mental illness, or weight programs with people with mental illness. And that's just one group on its own. And if we're trying to look at all the population, yes, it's very ambitious.
Okay, thank you very much.
Phil, any comments, questions?
No comments. I think the only thing I'd say is Meriden's right, in as much as some of the measuring is going to be quite challenging. However, if we do find a way for all partners to work together, then in theory, we should be able to capture some really interesting data.
Okay, thank you. Graham, comments, questions?
Yeah, first one is picking up on Carol's points. We agreed at previous Wellbeing Board that the two main bodies feeding into the strategy turning into action was the WIP, Wokingham Integrated Partnership, who had a primary focus on adults, and Children's and Young People's Partnership Board, who would pick up the children's focus, primary focus, with of course there would be overlapping between the two. So I think it's important that we restate that intention, that these are the two key working groups, or whatever we want to call them, bodies, that will keep an eye on and ensure that we have the right actions feeding into this overarching plan. And I was just about to go to the CY Children's and Young People's Partnership Board, and that was the very moment that we had the case with the school teaching assistant, the first COVID case, which meant that board didn't go ahead. So it will be good if we can pick up that momentum and intention again, which, as Carol says, would ensure that we have as much a children's focus on the strategy as we do an adults. The other point I wanted to raise is the strategy is based on 3 of our key objectives, overarching objectives: social isolation, physical activity, and reducing the inequalities, health inequalities gap. And it's always worth reflecting on, given we've gone through a crisis, are they still our key objectives within a strategy? And it's hard to think that they're not. If anything, all 3 issues would have exacerbated in terms of need across the borough.
Okay, thank you, Graham. John, any comments, questions?
No, very impressive.
David?
No, it's very good, and just measuring some of the things we need to measure won't be.
Okay, nothing from me. Debbie?
No, I think it's good just to have somebody else's eyes on what we're trying to achieve and get that feedback, but also good that we are making some headway towards achieving some of these goals.
Matt?
Nothing to me apart from just thanking Meriden for her input since March. That's been invaluable, and just to let the board know that Meriden's here on an interim basis. There will be a permanent appointment, Ingrid Slade, who will start in August, but Ingrid and Meriden will have plenty of time to hand over with each other.
Okay, thank you. Jim?
No, nothing again that I can add to what's already been said, quite frankly.
Katie?
Same as Jim.
Okay, and Chris?
Just one last thing, just one comment around. I think it is it's right that we have some concern around ambition. Equally, there need to be stringent targets around this, and in terms of ambition. But COVID has presented us with an opportunity where communities' well-being has been, there's been a culture shift for many communities in looking at their own well-being and their ability to improve their own health. So we may see a shift in some of those indicators as a result of increased physical activity, etc.
Okay, thank you. So I'm going to ask the committee if they agree to the recommendations in the report. Only speak if you do not agree. Good, I think that's agreement. So I'm going to say thank you to Meriden for that. And if Meriden, whenever she is ready, wants to move on with the next item, which is an update on coronavirus in Wokingham. And whenever you're ready, Meriden, if you'd like to introduce the report.
Yes, we're very coronavirus pandemic has hit this country pretty hard, and I have to say a pandemic across the world. Those of us in public health have been expecting this for years, and we knew that it would probably come from one of the countries that was dealing in illegal foods and meats and animals. And so pretty much this is what's happened. And this one is very different to the last, to the SARS, the MERS, and the previous swine flu. And sometimes you don't learn about a virus until it's actually quite significantly progressed, which is what is happening at the moment. So how does Wokingham fare in terms of the pandemic? There's a lot of data out there. And so what we're doing is putting a report in public once a week, so the public can see the progress. And what we're doing is making sense of a whole range of data. There's data from the Office of National Statistics, from the Care Quality Commission, from Public Health England, and there's lots appearing in all the newspapers. And I have to say, I get some of my data too from, Sky and the Worldometer and some of those. So there are lots of data sources for the public to look at, and a lot to get worried about. And not all of it tells a story for their local area. So what this does is try to put in perspective for Wokingham, and how do we compare to the rest of the country in particular. So if we move on to the slide. All right. So, for example, we've been doing a comparison across all the cases across Berkshire. And I think we all know that when we look at positive coronavirus cases, certainly in the first 6 to 8 weeks, there was very little testing. And so positive cases doesn't always give you the right story. And initially, they were only testing people who were sick in hospital. Then that moved to staff testing. And of course, recently, we're doing a huge amount of testing in care homes. And now anybody with symptoms, or any staff and key workers who even are asymptomatic, can get tested. So in terms of the incidence, what we've shown is the incident rates across the whole country. And initially, London had the highest incident rates of new cases. That then moved to the northwest. So the northwest has suffered the worst of the incidence new cases and the worst of the death rates. Wokingham is about average or just under average. And across Berkshire, Reading and Slough are above average. And so in terms of the local comparison, you can see the age standardised death rates on the next one. Then we get a chance to look at weekly death rates. Since the Office of National Statistics, for about 5 weeks now, have actually been giving us death rates per borough, per council area, local authority area, and also for care homes. It's the first time we had that data. So if we were to look at the most accurate way of looking at the impact of the pandemic, the most accurate way of looking at the pandemic is to look at all-cause mortality, and how does that compare with the same period last year. And for Wokingham, we're pretty much back to what you would expect for death rates at this point in time in the year. And it's the same for care homes, which is good. And the peak in Wokingham has been exactly the same as the peak across the country, and our peak was not as big as anywhere else. And the weekly death rates in care homes. Is fairly similar, and we can see that across all the Berkshire. And we also had a look at COVID-19 death rates by hospital trusts. And what's interesting is the Royal Berkshire is actually below average in terms of the impact that they've had in terms of deaths. And I think that has also translated into the impact of the hospital in terms of being able to treat everybody. There were trusts in London and in the northwest that had great difficulty, more so than we did in the southeast. And if we look at our deaths in care homes, which has been absolutely dreadful for most people across this country, Wokingham are fairly average. You would think that possibly because Wokingham have so many care homes that we might have been higher than average, but we're not. We're around about average. We've suffered similar to other people. And you can also look at, and one way of looking at the care home deaths is looking at the all-cause mortality compared to what you expect at this time last year or the last 5 years. But also if you look at the deaths per care home bed, and that shows that Wokingham is definitely not an outlier. Then there's the national picture of confirmed cases and deaths and how it's progressing in the country. And the other thing that's important to look at is who are the people who are suffering from COVID-19 more than others. And what's become very clear lately is that people from ethnic minority backgrounds are more likely to get the virus, secondly to get it younger, and thirdly to die from it, more so than other parts of the population. It is also a disease of older people. It's more likely in people who are vulnerable, and I think we all know what is meant by shielding and why people are being shielded. And it's also important to see how do we compare against other countries. We're similar to Europe. The United States haven't finished yet. And some countries have managed to have much smaller peaks and finish. A lot of it is down to culture and the way people live, the way politics happen. And there are just so many factors which will all be taken into account at some point when there's a debrief in the future. So that's a bit about the data and how we make sense of it. And the other paper that I've got for you is a summary which comes from evidence from other pandemics, emergencies all around the world. What are the impacts on communities? So I've given you a picture across the life course of the likely health impacts. And so these are the sorts of things we might like to think about as we amend our priorities going forward, or possibly as part of recovery. So that's all I wanted to say at the moment, Charles, but I'd be happy to take any questions if you want to.
Thank you. Excellent report, basically. So we're going to do this reverse alphabetically this time. So Chris first, any questions, any comments?
From me, Chair, it's very comprehensive.
Katie?
Yeah, it's very, very comprehensive. Meredith, I really like your impact of COVID-19 pandemic against the life course. I think this is something that needs to be taken up across all the partners, across Berkshire West. And actually what we've got to do is start looking at that life course and actually thinking about the services that are actually delivered, and actually thinking about how we go back into a restoration and recovery phase, ensuring that we're making sure we've got the right resources and the workforce numbers to support that actual life course going forward. So I'd welcome conversation with you, Meredith, about that.
Sure.
Jim?
Yeah, no, not really. Just to say that it's very valuable to see all of this information brought into at least a consumable form. That was it.
Thank you. Matt?
Yeah, just following on from what Jim said, that definitely was the effort here. And just to let everyone know that we are publishing this on a weekly basis and have been for a while on our website, so people in the borough can digest things easily and have one kind of summarised version of the truth.
Debbie? Debbie?
Oh, sorry, I was on mute. No, a great paper, and through this COVID, I've been working in the Reading Hot Hub, so kind of living and breathing COVID, both in hours, out of hours, and everything else. So agree with everything that's been said, and again what the others have echoed about that summary. I think we are beginning to see some of that come to fruition now. You know, it's been great that we've been able to do a lot of things online for some of these people, but you know, some of our elderly patients, just seeing somebody physically in front of them, they are absolutely over the moon. And I think we need to think about going forward about how we manage that. And again, what Martin was saying about people being concerned about now leaving when they've been shielded for 12 weeks is a big issue. Trying to get them to come into healthcare or outside without being concerned they're going to get COVID is quite a major issue.
Sorry, I was muting myself there. David?
sorry, I can't now mute. Yeah, I mean, I'll echo that helping people whose fear is to just go outside their front door, let alone anywhere near a medical facility, I believe is going to be quite something. I'm also interested, and that's Meredith doesn't look at this so much, about the future and how we might have another spike and things like that.
Okay, and next after David, it's John.
No issues.
John?
Charles.
Okay,
No.
Graham.
Just to reinforce Katie's point that life course extrapolated over the months and years ahead should be absolutely vital piece of information to inform our recovery, both at this council and as an integrated partnership.
Okay, Phil.
No comments from me.
Ulla Corinne. Ulla Corinne.
Sorry,
okay.
I muted myself. I just wanted to say that I thought it was a very good presentation and overview.
Thank you. And finally, Carol.
Nothing from me, thank you, Chair.
Thank you. Right, I'm going to say thank you very much to Meredith. That's excellent. And then we'll move on to the next thing, which is integration update. Now, my notes say Charles to ask Lewis Willing, Martin Sloan, or Katie Summers to introduce report. So can whoever is introducing the report please step forward? My apologies. I've been asked to have a vote on the last paper if we agree with the recommendations before we start this. So again, same rule as before. If everyone's happy, please stay silent. Lewis, my apologies. The floor's yours.
Good afternoon. My name is Lewis Willing. I'm also another newbie to the borough, along with Meredith. I've been here for a whopping 3 weeks. So I'd like to take you guys through very briefly the response to COVID with the Wokingham Integrated Partnership and the SIPREP calls which have been taking place, and also the Better Care Fund Q4 return, which is due to be submitted. So the situation report call is taking place now fortnightly at 1 o'clock, and it's the whole of the Wokingham Health and Social Care system meet virtually to discuss current issues of the day. There's really good attendance at the meetings, and we're joined by partners from our primary care networks, represented by our clinical directors, BHFT, the voluntary sector with Involve, thank you, Phil, the Berkshire West Clinical Commissioning Group, the council, which is represented by both adult social care and public health, and we get updates from the Royal Berkshire Hospital. As Martin has already suggested and explained very clearly, the work so far has focused on the shielded group, but just to add a bit of flavour to that, that's led to more than 5,750 calls to the community to offer welfare checks and direct people to services that were available. And as Martin said, there's now a focus on the non-shielded vulnerable groups. As an example of a success of the meetings, it was noted that there's been an increase in the number of safeguarding referrals for babies that have been shaken, sadly, during the current restrictions that have been in place. This was noted by our colleagues in Berkshire Health Foundation Trust, and as a result, they restarted the health visiting service to support our new parents in the borough. This is a service that's commissioned by the council. Also, our primary care networks did some virtual consultation work with new mothers, which was very well attended. A really positive step, I felt, for the people, young people in the borough, and also for the parents that may be having issues and struggling. Our primary care network directors have fed back to the group as well. They have plans in place to develop GP surgeries to support social distancing, develop some NHS demand management tools which will support them in their role, digital triaging, again, to support our surgeries, and they are holding digital group consultations for cohorts in the community, which are at risk in the COVID environment. So people with asthma, anxiety, and young people with mental health issues. These have started and they've had good feedback. So to move on to the Better Care Fund return for Q4, since the submission of this paper, there's been a further delay to us submitting, with the deadline now from NHSE being the end of July. We don't even have a date, unfortunately. However, the submission will remain the same. We have our 4 targets, the first of which is around non-elective admissions to hospital. For this target, we are on track. We're slightly above the target, but there's a 5% tolerance, which means that we're reporting as on track. The next is regarding residential admissions, which we are also on track for, and a real shot in the arm for the system overall, I believe. The system has supported only 113 admissions to residential support this year against a target of 138. So that is something to be proud of and to be congratulated the system overall. Next, we have our reablement target. Again, we are on track for this, slightly above the target, but again, with a 5% tolerance, we will be fine. The main challenge during this year has been that we've historically set our target based on local authority reablement data only. Within the first 3 months of 1920, we have been able to include our health reablement data as well, which we haven't been able to previously do. So that's another real benefit. Unfortunately, the delayed transfers of care can't be said to be such a rosy picture. In Q4, as with the other quarters, unfortunately, we are higher than target. And overall, for the year, we will be higher than target, this last quarter, substantially so. We have seen a significant drop in March compared to the previous 2 months, and this is likely due to the new hospital discharge process, which has been introduced to expedite discharges due to the COVID-19 pandemic. There's going to be further work on seeing what we can keep a hold of for these services in the future. Also worthy of note, our DTOC action plan and winter pressures funding are being targeted to support reducing delays in hospital, with the main issue being noted in 1920, an increase in duration of stay for a very low number of people with complex needs. So further thought is going into how we can support those people using our winter pressures funding. The final part of the submission is linked to the 8 high impact change model, which offers us a practical approach to managing transfers of care. It's used by NHSE to assess how local care and health systems are working now and to plan actions to reduce delays. It's expected that all of the Health and Wellbeing Board areas are rated as either established or above, with mature and exemplary being the best. As we report on this as a Berkshire West system, as we have a shared assessment because we share hospitals, most notably the Royal Berks and Prospect Park. In the west of Berkshire, for early discharge planning, we're rating ourselves as mature. For systems to monitor patient flow, established. Multidisciplinary team and agency working, again as established. Our home first and discharge to assess is established. 7-day services established, trusted assessors established, focus on choice as mature, and enhancing health and care as mature also. As such, we've met or exceeded the expectations of NHSE, which is again very positive. Whilst we are graded across the west of Berkshire as mature in enhancing care in healthcare, there is still work ongoing to support our care homes as a result of the COVID-19 outbreak. There's currently a plan in place being developed to support our care homes locally, especially around infection control. And each week, Berkshire Health Foundation Trust, the Clinical Commissioning Group, the Council, the other 2 local authorities in the west of Berkshire, the primary care networks and the care homes themselves are working together to offer support and guidance as where we can. The last part of this report is linked to the integration highlight, which we always put in our returns each quarter to sort of say some of the wonderful stuff that we're doing locally with regards to integration. But this has already been covered by the Designing Our Neighbourhoods discussion earlier, so I won't reiterate. And with that in mind, do we have any questions?
Okay, thank you very much. This time it is alphabetical, so any questions? Carol?
No, thank you.
Ulla Corinne?
No, none.
Bill?
Nothing from me.
Graham?
No, not for me.
John?
No, not for me.
David?
No, thank you.
Debbie?
No, thank you.
Meriden?
No, thank you.
Matt?
Nothing apart from welcome, Lewis.
Jim?
Not from me.
Katie?
No, it's just a recognition of Lewis, and he's come to Wokingham in a very, very hard time, and it's a big thank you to him that he's embraced this role and actually really supported the system. So, Chair, I just want to recognise Lewis in this because he's done excellent work. Well done.
That's very, very kind of you to say. Thank you very much.
And finally, Chris.
No comments, Chair, apart from well done. Thank you.
So thank you very much, Lewis. Now I have to ask the committee if they agree with the recommendations within the report. So again, same as before, if there's silence, basically we'll take that as acceptance. So thank you very much. Thank you, Lewis. So now we're moving on to the Wellbeing Board overview report, and it's Narinder or Matt to introduce the report.
I think it's going to be me, although I'm sure Narinder will chip in and correct me as necessary. Good evening, everybody. There's been some really good reports today with some really useful information. I'm afraid this one's a bit drier, so I'll be as brief as I possibly can. Peter, can you take us to the recommendations page, please? That's all going to make us a bit seasick, I think. The recommendations bit of the report, is that there? So the idea of the report here is we haven't met for a while. So we just put a report together to kind of summarise where we are with the Wellbeing Board. I'm not going to go through that in great detail now, because I think everybody can read that at leisure. But there's some useful reminders around what the Wellbeing Board, the aims of the Wellbeing Board are, some good practice workshops that were done a while ago. And what we're looking to do is just remind people that for future boards, we're going to be a little bit more stricter about agenda setting and papers, and making sure papers are in on time and out. And also, we need to do a bit of work on sharpening up our forward programme with regards to the board agendas and the informal boards, and improving that kind of forward look. So one of the suggestions is that we don't have a long conversation about that tonight, but what we will do is ask for suggestions to be sent in to Narinder in the next week or so, and then we'll kind of knock together that forward plan for discussion at a later date. Are we able to actually go to the recommendations in the report? Because there's some sort of housekeeping to be done. There's some subgroups that haven't met for a while that I think we should disband unless we feel they are active, which I don't think they are. It's the covering report that got the actions in, I think. The recommendations in. Okay, so they're mainly bullet pointed through on that page there. Okay, so I'm going to keep it brief. That's what this report was about. Any questions, and then just supporting the recommendations. Charles? Charles? I think you're on mute, Charles. Charles, you're on mute.
Apologies, I said my internet gave up a second ago, so I'm guessing you've just finished presenting that.
Yeah.
Okay, great. Well, then we'll go around and we'll do any questions. It's alphabetical order this time. So, Carol, any questions, any comments?
No, thank you.
Corinne?
None.
Phil?
Nothing from me.
Graham?
No, not other than supporting the need for us to get clearer and sharper in our work.
John?
No, but don't forget any other business.
Of course. David?
No, but I quite agree that we need to get a lot better in our work with this.
My comment, which John referred to, any other business, which I'll mention now, the government obviously is launching the track and trace programme, which all of you will be aware of, which obviously the council via the Wellbeing Board is meant to be responsible for management of. Now, there's very little detail that's actually known apart from this fact yet, and the suggestion to propose to deal with it was to set up a subgroup of the Wellbeing Board under John Halsall as leader of the council to obviously coordinate response to that involving the various key people. So it was really just to advise people that that's the intended plan and to welcome any comments, suggestions regarding that aside, outside this meeting. So moving on, Debbie, any questions on the Wellbeing Board?
No, thank you.
Meriden?
No, thank you.
Jim?
No, thank you.
Katie?
No, thank you.
Chris?
No, other than that, the recommendation seemed prudent. So thank you.
Okay, good. Well, thank you for that. I've got to ask the committee. John Halsall is asking to speak. So, John, when you're ready.
Just an addition word on what Charles has said is that the government appears at the moment to be saying that the health and wellbeing should be responsible for track and trace, and the leader should be responsible for the health being board, which is responsible for track and trace. So the sensible opportunity is to have a subcommittee, which I chair, so that fulfills both of the criteria of the government. And the composition of it is to be decided, really, because we don't really know at the moment.
Okay, thank you for that. So if everybody is in agreement, and I'll be silent for 5 seconds, then we'll then move on to the next item. And that's everybody in agreement. So I think that is then Wellbeing Board Annual Report. Matt, is that you again?
It is, yes.
When you're ready.
Yeah, we'll just wait for it to pop up. So annual report we've prepared this in a kind of final draft form. This goes on to full council in July, so we have chance to amend and shape should we wish to. I won't step through it bit by bit because I'll assume that people have read it. Most of what it does is describe all the work that we've achieved over the last year, some of which we've heard about tonight. I think the important bit for us is just to dwell on the what's next, what's coming up for us in the next year. So if we can go to that bit in the report, Peter. I know I've challenged you a bit in terms of jumping around reports, because I think it's important that as a group we broadly agree the work programme on this page. Now, a lot of it we've talked about today. We've talked about making sure children's are more prominent in what we do. We've talked about the priorities at WIP, etc., etc. I think the bit that we need to add to this is what Charles and John were talking about in terms of the board and a potential subgroups role in COVID and the COVID response and track and trace going forward. So I'll be proposing now to add in a kind of another section there to the report going forward. And then I think I'd be broadly satisfied that this report could go on to full council. So happy to take questions.
Right, we'll go around again. Chris? Katie, any questions?
Sorry, thank you.
No problem. Katie?
Nothing from me. That's absolutely fine. I agree with it, and I'm happy with those priorities and what John was actually saying.
Jim?
No, I think this is all agreed anyway.
Yeah, okay. Meriden?
No, nothing more from me. Thank
Debbie?
you.
Fine with it, thank you.
David?
Yeah, it's fine, thank you.
John?
Thank you. Nothing, thank
Graham?
you. The only thing from me would be the work priorities. If it's not clear, and I might have missed it, is making sure that they are aligned to our 3 strategies: social isolation, physical activity, inequalities gap. Just spelling that out if we can. That would be all from me.
Okay, Phil?
Nothing from me, Chair. Just say equally, I've got to leave the meeting now, I'm afraid. So apologies.
Well, thank you very much, Phil. Ulla, Corinne?
No, I have nothing.
Carol?
No, nothing further, thank you.
Okay, great. Well, thank you very much for that. I've got to ask the committee if they agree. Only speak if you do not. Okay, and now we're on to the forward programme, and my notes say chance to go around each member in turn in reverse alphabetical order if there's anything they want to speak about. So is there anything people want on forward programme which is not there? Chris, Katie, Jim?
The only thing I would actually add on for October is going to be, at the moment, the CCG is pulling together their updated operating plan, and I think it's worth adding it on there and should be ready by October.
Okay. Matt?
Nothing from me.
Meriden?
I think it may well be important to have another report on COVID-19, and this time it'll be how well test and trace is working and whether we've managed to contain outbreaks.
Okay, agreed. Debbie?
I was just going to say the same thing. I think we need a COVID update, but also to kind of update kind of where we are, because will have been giving out flu jabs at that point. So there's going to be some confusion over normal flu and COVID.
Okay, I mean, my thing for the forward programme would be, obviously, Matt's mentioned the reforms we're looking to make it sharper and a bit more, this meeting a bit more decisive, and comments to Narinda. And I think perhaps a short paper summarising what comments and feedback come back so we can move that discussion forward. David, anything for you?
No, I think that's everything. Thank you.
John?
No, that's fine.
Graham?
Just a pitch that designing our neighbourhoods and strategy into action remain as standing items going forward.
Okay. Phil has gone, so Ulla Corinne?
No comments.
Carol?
My only comment is, at some point you'll probably want to see the Children and People's Partnership action plan or alignment to the priorities. I'll have to do that piece of work. People like work first, and then I can present something is in the calendar.
Okay, thank you. So that is it from me, unless there's any other business. I'm not going to go round. If there is any other business, please say so. Okay, well, I will say thank you very much in that respect, and yeah, thank you for your time, and thank you also to Dorinda and Peter have been supporting the meeting. And therefore, good night. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Bye.
Thank you. Well organised.
Good night.
Thank
Bye-bye.
you. Well done.